Good morning, everybody. Thank you, Mr. Chairman, and the organizing committee for getting the opportunity to present our data of this study. So, here we go. The study was performed by the University of Lübeck and the University of Cologne, and the title Pulmonary Outcome of Very Low Birth Weight Infants Following Preterm Premature Rupture of the Membranes. And I will show you the data of combined surfactant-budesonide treatment, and I'll also show you data of the German neonatal network. My conflicts of interest are here, and here we go. Topical steroid treatment has become, or has got into the focus of neonatology during the last years. So you maybe all know the data from the neurosis study where budesonide was given by aerosols into the lungs of preterm neonates, and you also heard maybe this morning Dr. Yi talking about surfactant-budesonide. And we came into the field a few years ago when we were treating this baby here. It was a 27+3-week boy, 1100 gram, and the mother had a premature rupture of the membranes at the gestational age of 20 weeks, following anhydramnios. She got antenatal steroids and antibiotics and so on, and in the 27th week there was an emergency C-section. We had to resuscitate the baby, and initially we got inefficient ventilation, bradycardia, we need to do chest compressions, and there were additional problems. These babies have deformations, in this case fascial deformations. We had no access to the airways via the nose, and we need to oral intubate the baby and in order to give immediate surfactant. This worked not that good. When the first X-ray after surfactant treatment was done, we saw this white, tiny lung, and I would call this situation a dry lung syndrome. We had to escalate the therapy during the course, and we had to give additional surfactant doses. We need to apply high-frequency oscillation, had to give NO, and nothing. The situation did not improve that well after the third and after the fifth dose of surfactant. And then this surfactant-budesonide study of Dr. Yi came into my mind, and we gave at the age of 10 hours, when we still had 80% had to give 80% oxygen under high-frequency oscillation, we gave the first dose of surfactant plus budesonide. And during the following night, this baby improved rather well. Okay, when looking at the literature, what is the dry lung syndrome? If you find rare literature about this, McIntosh said that it is maybe a functional hypoplasia of the lung rather than a true hypoplasia. Siegel wrote that it is an under-recognized clinical entity, and there are some more papers proposing some management strategies, some prenatal diagnostic strategies that are maybe hardly to do. 3D lung ultrasound, okay, maybe. Fetal lung MRI with women that had a PPROM. I don't know if it's possible all the time, maybe not. Prenatally, steroids are often given to these women. Antibiotics, of course, tuberculosis is done. And then there are some centers in Germany that try to normalize the amniotic fluid content. Again, this maybe works, maybe it not works. And postnatally, we have different ventilation strategies. We can give surfactant, and we maybe give pulmonary vasodilators. Our protocol was, after this index case, to start talking about these women already prenatally by doing an interprofessional prenatal board. We want to win time, if possible. We want to give the antenatal steroids, antibiotics to the mothers, make a risk monitoring, and postnatally, we were collecting the data of the babies that were treated. So if the gestational age is below 36 weeks and the mother has the oligo or anhydramnios longer than 3 days, and the baby develops a clinically severe RDS with the FiO2 above 30% and the CO2 above 60 millimeter mercury, then we treat these babies at the moment with surfactant-budesonide. And we are following up these babies until the age of 2 years. And to compare a little bit the experience of this observational group, we looked at our big network of the German neonatal network, where babies below 1,500 grams are enrolled since 2008, and there are 19,000 infants already in this database. And these babies are followed up until the age of 5 years by the help of on-site monitoring. So the aims of this presentation of this study was to look at this jEN database babies with PPROM, and we only have the item of PPROM longer than 5 days, and compared to the control group. And then I summarize the experience of the babies that were treated with surfactant plus budesonide. Here are the results of this analysis. So in the jEN control group, we have 9,000 babies. jEN PPROM during 10 years, 480 patients, and the surplus cohort are meanwhile 26 patients included. The gestational age in the jEN is 28.8, and it is significantly lower in the PPROM group. And the PPROM babies had a lower birth weight. They were getting antenatal steroids at a higher percentage, and the latency of PPROM was, of course, significantly higher. But it was even higher in our observed group with 3.7 weeks, plus minus 2.5. And our babies that we looked in our small cohort were even smaller and at a younger gestational age. Here are some data of the morbidity and the mortality. So we have in the jEN mortality of below 5%, and it was significantly increased in the group with PPROM longer than 5 days. In our observational cohort, we have higher mortality. Of course, as I said, these were tiny and sick neonates. If you look at the BPD at 36 weeks, it was significantly increased in the PPROM group compared to the jEN, but it was similarly in our observational study compared to the jEN control group. BPD or death, the combined outcome was significantly higher in the jEN PPROM group compared to the jEN. We had higher rates of pneumothorax in the PPROM group of the jEN and higher rates of IVH. And whereas in our observational study we had similar BPD or death outcome and higher rates of pneumothorax and IVH of 1 and 2. The duration of respiratory support is always an interesting parameter to look at. If you look at any kind of respiratory support, conventional ventilation, high-frequency oscillation, CPAP, and also nasal high-flow cannula, then we have significantly longer duration in the jEN PPROM group compared to the jEN controls. and an even longer duration of respiratory support in our small cohort of around 60 days. And supplemental oxygen was given longer in the jENS PPROM group compared to the controls, whereas it was similar in the surplus group, and the duration of conventional ventilation itself was short. It was around 7 to 8 days in the PPROM groups of the jENS and of the surplus group. If you look at the discharge, then we had a discharge at gestational age corrected of 41.1 weeks, which was longer compared to the jENS PPROM groups, which was at 38.7 weeks. And if you look at the outcome parameter of the respiratory rate, then it is these babies at discharge have a high respiratory rate, and this might be a parameter that we can compare during the follow-up. So, compared to controls, the jENS PPROM babies have a longer respiratory support. They need longer respiratory support. They show a higher morbidity and mortality. This is significantly. I don't know what the effects of the surplus treated babies means. These babies are, as I showed you, clinically sick and tiny, and the effects of this treatment remains unclear, but we have to recognize that a lot of centers in Germany use this treatment, and for me it is a black box like this at the moment, and I think that we have to think about doing a randomized study, but as you saw, this is hardly to achieve maybe, because these babies are not that much, and we have to combine our profession of and do a multi-center study. So, thank you for your attention, and I'm looking forward to some questions.